Good. I think it's a little better. All right, guys, I think we can make a start. Three, two, one. Pleasant good afternoon, everyone. I would like to welcome you to our Rural Seeds webinar for the month of May under the theme Transforming HIV Care by through empowerment and stigma reduction in rural communities, as is seen in Guyana. I'm happy to have an esteemed panel of healthcare workers who would have served various parts in rural communities of Guyana. I have Dr. Lakshmi Narain, our Care and Treatment Coordinator of the National AIDS Program Secretariat, Dr. Keisha Chin, the SDI Coordinator at the National AIDS Program Secretariat, and Medex Judy Atkinson, an HIV officer that works with the Ministry of Health. I'm your host for this session, Dr. Tariq Narain, one of our Rural Seed Ambassador and also a clinician. And allow me to say welcome, you lovely ladies.
Thank you, Dr. Narain. Happy to be here.
I trust that you're having a wonderful afternoon, morning, or night, wherever you are. And you're excited to share your experience working in rural communities, but not only providing a primary health care, but specialized care when it comes to HIV. And so, without further ado, allow me to go into the session by introducing our first speaker, who is none other than Medex Judy Atkinson. So, Medex Judy, she is a seasoned care and treatment healthcare worker. She's been working in primary healthcare for over 11 years as a Medex. That's somewhat of a position that is associated in some parts of the world as a physician assistant. And she's also worked as a midwife previously in the beginning of her profession. She plays a vital role in primary health care by focusing a lot on health promotion as well as prevention of medicine. Medex Atkinson would have spent quite a number of years working in a rural community of Guyana referred to as Waramuri. That is found in Region 1 at the top of Guyana in a larger village referred to as Maruka. And she would have mentioned that her time spent there, she would have had several memorable experiences that I'm sure she will share with us. She has spent almost 6 years dedicating her services toward the care and treatment program for HIV, offering services to persons living with HIV and providing a lots of preventative medicine and care to these individuals. And so we welcome you, Medex Judy Atkinson, and we would like to hear from you, your experience in providing community-based prevention HIV services in the rural communities you would have worked, and share some of your success stories of what it has been like over the past 11 years. Over to you.
Hello, good afternoon, everyone.
Good afternoon.
This afternoon I would be discussing community-based approaches to HIV prevention in the hinterland region, and I will share some successful examples of these approaches in Guyana. So community-based HIV prevention intervention have been designed to improve HIV-related knowledge, which help to reduce engagement in high-risk sexual behavior. It also encourage regular screening.
You want to share your presentation if you have? It's okay to go ahead and share the presentation, Medex Judy.
Yes. To encourage regular screening with the ultimate goal of decreasing the transmission of HIV. So our first prevention intervention is community engagement. But I must first say that the government of Guyana and other organizations such as the CDC, PAHO, and Global Fund sponsor activities for intervention and capacity building in all the hinterland region, which is region 1, 7, 8, and 9. And because of this, NAPs are able to conduct health outreaches to the hinterland regions. And on those outreaches, we collaborate with other health programs such as adolescent health, men's health, women's health, and the expanded program for immunization to capture the different age groups. So we network with local organizations within those communities within the hinterland regions. And we network with other institutions such as the schools to target adolescents. And we network with churches, women's and other youth clubs. We create partnership with community leaders such as the Tushao and the counselors and other key informants from the various hinterland villages to develop tailored intervention that address specific challenges. So in terms of education, we conduct comprehensive HIV awareness campaign to educate community members and provide information on HIV, how it is transmitted, and we make them aware of the different preventative measures that could be taken. So another strategy for prevention of HIV in the hinterland is addressing stigma and discrimination. Because of stigma and discrimination in those small communities where everyone knows each other, it affects treatment and prevention in terms of providing prophylaxis treatment for HIV. So that impact on us trying to achieve our 95, 95, 95 goal, which is set for 2030, where we want 95% of persons who are infected know their status, and the 95 to start treatment so that they could be virally suppressed. And in them being virally suppressed, it would help to reduce the risk of transmission of HIV. So the National AIDS Program Secretariat utilized community meeting to sensitize people about HIV, as I mentioned before, right? And they utilize the social media platform where we share information, right? But in some of the hinterland regions, some area we don't really get social network, right? Because the area is really remote, so we try to reach out to them through outreaches. For the care and treatment sites in those regions, they offer counseling. So couples, discordant couples, so that they would be very supportive to the partner and to family members of those who are affected, so that they could offer support and they would be less discriminated. We also have support groups where they share experiences, so they feel more comfortable when receiving care within those areas. So the next strategy is HIV screening. So for all the regions in Guyana, we have testing sites. We ensure that all clients are counseled before and after a test. So if the test is negative, we would advise them on ways how to remain negative. And if the client tested positive, we would counsel them and advise them on ways on how to prevent transmission. We also ensure confidentiality And outreaches, we established mobile clinic where we could reach out to others who are unwilling to come to the treatment sites to be tested. We have community health workers in those areas that would usually do monthly home visits. And they have like basic knowledge that they could pass on to the residents and encourage them to be tested. And sometime on those home visits, usually a medical team would visit, like which includes a council tester, and they would do testing for persons who are willing to be tested. We also promote pre-screening, which is HIV self-testing. So on outreaches, we target our at-risk population, which are the migrants, MSM, and adolescents. So at like most of the checkpoints for the hinterland region, we would place like great emphasis in terms of testing the migrants. We also we also visit mining camps where we conduct testing. So during testing and counseling, we tailored our prevention effort to address the specific need of the person who is being tested. So we also promote like safe sex, the use of condoms. We have treatment that can be used to prevent HIV. We call it pre-exposure prophylaxis. So in Guyana, we administer the Truvada for pre-exposure prophylaxis. It can be taken daily or it can be taken on demand, which we refer to as the event-driven or the 2-1-1 dosing, where we would give two tablets 24 to 12 hours before sexual encounter. And then we would give one tablet 24 hours after you take the 2 doses. And then 24 hours after, then we give an additional tablet. So it's not a standalone strategy. So we encourage condom use as well because the prophylaxis cannot protect you from other sexually transmitted infection, right? And we also do regular screening on persons who we placed on prophylaxis. We also have post-exposure prophylaxis. That are drugs that are taken in the event of a possible exposure. For example, in the event where someone is sexually assaulted or where there was a tear in the condom during sex, or in the case of needle stick injury. But those persons have to use the ARV within a given time frame, within 72 hours of exposure. So in Guyana, we administer the TLD or the AAA as a post-exposure prophylaxis.
And all of these are used also in the rural communities that you work, no?
Yes, yes. And
Excellent.
we also have post-exposure prophylaxis for children as well. In terms of prevention, mother-to-child transmission, we encourage the mothers within those rural communities to join clinic early, right? So on admission, we would screen them for HIV, right? So if they're if they're tested positive for HIV during screening, then we would start treatment immediately so that we could prevent transmission from the mother to the child. And we also counsel them on in terms of after delivery, what measure can be taken, like for example, no breastfeeding and just feed formula, feed for the infants. And then we also provide prophylaxis treatment for the infant when the baby is being born. So we also, in terms of treatment, it also works as a preventative measure for reducing transmission. So we encourage persons who are tested positive to adhere to the treatment, take the treatments, the ARVs correctly, right? So that they could maintain an undetectable viral load. Because once the viral load is undetectable, the risk of the person transmitting the virus to someone is very low. They say an undetectable viral load equal to untransmittable. And like I mentioned earlier, we collaborate with other health programs, adolescent health and women's health and men's health, to promote HIV and other STI prevention strategies.
Amazing work, ma'am. No doubt. Do you want to share with us any success stories that you would have had while providing prevention services to persons within rural communities of Guyana?
Well, we recently started providing prevention services in terms of the prophylaxis treatment to the hinterland region. But in terms of health education and so on, the youths, they were very involved, and they respond more to being screened, not only for HIV, but for other STIs.
Okay, is there any additional information you want to share with us? We no doubt you shared a lot around prevention. Any last few words based on this specific area?
One of the challenges I find as it pertains to care and treatment in the hinterland region is because most of those hinterland regions, the community is very small. Everybody know everybody there. So in terms of access and care, they would prefer to access care out of the region, which sometimes, add, which sometimes affect adherence for
Thank you
clients.
so.
Yes,
Oh, sorry for that. I thought you were finished. My apologies.
it's okay.
Thank you so much for that. Definitely, you would have shared a lot in terms of what is being done in Guyana, not just generally, but also in rural communities, talking about community engagement, getting multiple stakeholders involved, trying to do outreaches, especially in areas where they may not have all of the resources. I'm pretty sure, like many other rural communities around the world, resources and availability of services are always a challenge. And so you did mention many collaborations that you do with other not only ministry departments, but also other NGOs as well as donor agencies. I like the idea of you sharing of you guys networking with a lot of the persons within the communities to promote community ownership and community involvement, especially where there are areas of deficit and focusing on that. And I'm sure that the small communities, despite stigma and discrimination, can be a challenge. I know Dr. Chin, our speaker, our third speaker, is going to share a little bit more on that. But that in itself is something difficult to navigate. And many other communities are working around that area. Internet access is and access towards resources to use technology is always a challenge. And so I like some of the stories that you're sharing that you would have that communities use generally that you've worked to mitigate those challenges and the ability to work with youths as an example, to promote prevention services because they are the future of tomorrow. And so, thank you so much for sharing those kind words on prevention services in the rural setting of Guyana, Medex Judy Atkinson. And we now move on to our next speaker, who's none other than Dr. Lakshmi Narain. She will be speaking about ways to enhance HIV care within rural communities and share some of her success stories. So before she speaks, allow me to tell you a little bit about Dr. Lakshmi Narain. Dr. Lakshmi Narain is the current care and treatment coordinator at the National AIDS Program Secretariat. She is a clinician and a dedicated healthcare worker for over 9 years. She would have worked not only in multiple primary healthcare facilities on the coastline of Guyana, but also within rural communities. She would have acquired her medical degree from the University Latin School of Medicine in Cuba, but also she's pursuing additional studies, a master's with a focus in epidemiology and international public health. She would have been involved in many activities that combat disease outbreaks, as well as coordinating efforts for persons living with HIV during the COVID-19 pandemic, especially in rural communities. And Dr. Narang would have pointed out that through her work over the past few years, she would have been able to collaborate with many governmental agencies, international organizations, as well as communities, bringing services to the people, especially in Region 7 where she worked. And I'm sure she'll tell us a little bit more about Region 7. And so her entire aim as the care and treatment coordinator is to help collaborate with the team at NAPS to provide evidence-based medicine policy changes as well as intervention that can tackle the HIV epidemic towards achieving the UN AIDS 95 95 95 target. And so, without further ado, allow me to hand over to Dr. Lakshmi Narain. Please go ahead, share your screen, and we're excited to hear from you.
Good afternoon, Dr. Jagnarine. Thank you so much for that wonderful introduction. I hope you can hear me clearly.
Yes, we are. Go ahead.
So this afternoon, I will be talking a bit about enhancing HIV care through community engagement. As Dr. Jagnarine mentioned, I would have been stationed in the hinterland area in Guyana for a bit over a year, and it would have given me a great appreciation of the challenges faced by those communities in accessing care, not only for HIV, but basically for any health-related illness. So one of the things then that you have to focus on when we talk about HIV care in communities and rural settings is it's critical for improving health outcomes and ensuring access to community is that we want community engagement. So a few key points that we want to take notice of would be, as Medex would have mentioned before, establishing local support networks. So creating local support networks is one of the most important things that you can do in a rural community, especially where a community so small, it's close knitted, and you will find that most of these communities, they're faith-based communities. One of the things then that really helped myself and team when I was based in the hinterland community would have been to involve the church in whatever health related issues that I would have liked to address, not only HIV, but you find that when church leaders and elders they take the initiative and basically put that step forward, that the congregation listens because this is someone that they look up to, they value their opinion and they respect, they go to for advice. So if they feel that inclusivity coming from such a leader, they're more likely to listen and be engaged. The other point that we want to take into consideration would be the use of community health workers. Now, you want to train and empower community health workers who are familiar with the rural context, the culture, and the language in these communities. Now, these community health workers, even if they do not provide treatment per se as ARVs, they can provide education, counseling, psychosocial support, and so on. However, one of the things then to take into consideration is that I would have found working in Cameroon is that Persons living in these community, although they engage with community health workers from their terrain, they would have been a bit more open to persons who would have been outside of their communities. Persons who they had no relationship with and they had a possible conflict of interest with. Say if it's a cousin or it's a neighbor or somebody up the river. They would have felt more comfortable with persons who are, as we like to say, outsiders or coastlanders. And a great example is this: when we were in Camarang, persons would have
Where is
preferred.
Camarang, Doc, for our listeners who may
Okay,
not know where is Camarang?
it's located in Region 7 in Guyana, Upper Mazuruni District Hospital. It's a plane ride away from the Georgetown. It's about an hour 15 minutes, and it's a beautiful, beautiful community, really, really lovely. And you have 13 different health posts that are managed under one district hospital. So basically, we manage the health posts with the use of radios. So you got to make sure that you're always charged when the sun is out. So the other thing that I would notice is that these persons living in these communities would prefer to come to myself and the other doctor stationed there, Dr. Prasad, rather than going to the doctor that was trained from their community for services. So that's a big indicator that persons feel more comfortable with someone who they possibly have no relationship with, and you're not really interested in who they're related to and who they're not related to. So that is something to take into consideration. However, we cannot forget that persons who are familiar with the layout and the culture and the language, you cannot forget the importance of those persons because there are communities where you have a language barrier. So one of the other things we want to look at will be culturally tailored education. So you want to develop materials and campaigns that are culturally sensitive and relevant to rural communities because sometimes us as medical personnel or physicians, we take for granted the impact that cultural beliefs have on medical care. So it's important to look at the intersection between that cultural belief and medical care and see where it is that you can fit in your consult and your education and advice and your messages about prevention, treatment, and care, and so on. To basically respect what those individuals believe in and to, I'm not going to say downplay basically what they believe in because every person has their personal beliefs and it is our job as physicians to respect that belief, right? So peer support and mentorship is it has been a great help to our HIV program in Guyana. We have seen this through our our support groups. We have our seronegative group as well. We have a body system and we have peer educators. So we use these individuals who are in the system to basically connect with persons that we want to bring into care or persons that we would have lost from care. And as my colleagues can testify, our loss follow-up system, it has gained traction since we have employed these strategies and we are seeing improvement in our 95-95 targets. So that's a big gain for us there. And when we talk about HIV care, we want to remember that it's not just about treatment, but we have to look about prevention as well. So community health fairs and outreaches. When we do community health fair and outreaches, what we want to do is you want to collaborate with providers, NGOs, your community leaders. In this case, you want to make sure you inform the Tushaws, the village counselors, get them involved and have them be part of these efforts, help them so that they feel included as well and they're more likely to implement any evidence-based strategy that you will bring to their attention. So that way you have an integrated approach. You do not only bring HIV services, but you could also offer testing of blood sugar, blood pressure. You could do VIA. We could test hair aid, you could offer eye testing services and so on. In this way, you do not stigmatize or discriminate against anyone as well. It promotes an integrated and community-based approach, which is what we're looking at. So, home-based care and treatment in rural settings, it's basically limited because you don't have much health facilities or personnel. But something that I would find very rewarding, enriching, and basically beneficial to not only myself and the community would be going out into the communities once per week. We would have dedicated 1 day per week when we go into the community, and when we go into the community we bring services to everyone. So it's not only targeted towards HIV patients. So when we go into the community we look at persons who are elderly, disabled, the little kids, the pregnant mothers who would have missed clinic and so on. In that way we look at every aspect of health, and you treat a community not only based on the amount of persons living with HIV there, but on their health needs. So that way you build a relationship with these persons in the community, and they are more likely to come to your health center, come to your hospital for care, because they see that you extend that care towards them and that you actually have an interest in promoting health and promoting care for them, for their families, their friends, and their communities as well. So, addressing stigma and discrimination, Medex would have touched a bit on this topic, and Dr. Chin will further address this as well. As Dr. Chin will probably tell you, stigma and discrimination is one of the biggest issues that you have in small community settings, especially in the rural settings in Guyana. One of the things that we try to do is promote a supportive and inclusive environment for PLs, and you want to eliminate any misconceptions. But this here, it's great using our pastors or imams or pundits. It's great to use it to show the village counselors, because these are the persons who could get the message across for you. Sometimes it's not going to be you who's going to get the message across, but it's going to be the persons in the community, and that's a great help for you as well. And as you know, stigma and discrimination, it's one of the biggest barriers to care, and something that we still work at overcoming in Guyana. Luckily, in our setting, I find that the religious leaders, they are to some extent open to listening, to being educated about the dangers of stigma and discrimination. So that's a big help in our setting in Guyana. So leveraging existing community structures, this is an excellent idea as well. You want to use structures and self-help group, women's group, farmers, and so on to get your message across. Again, these are people who are already in the community. They're respected, they're well loved, and if you can get them involved as well, they would find that you come into their community and you respect them and their positions as well, and they will be more open to helping you get the message across. One of the things that I find really helpful when I was in the hinterland community was using the activities, them basically in engaging the headmistress in Cameroon and using the school as a place to disseminate the message about HIV, about women's health, men's health, as well as the church. So you have to engage your community leaders and use whatever is available to your advantage, because remember, in these communities the resources, as Dr. Jagnarin would have indicated, it's a bit limited. There's not always that access to internet for information, so you would be the one who would bring the education to these clients. So it's important to bring the information from someone they are familiar with and they respect, and they will feel that it's more inclusive. They're not being stigmatized or discriminated against. So Medex briefly touched on mobile clinics and outreach services. So one of the things that I find very helpful is that when we do mobile clinics and outreach services, we want to focus on an integrated approach as well. You want to bring this service at a convenient location for the community. And one of the biggest challenges to persons in rural communities, especially in Guyana, we have a lot of satellite villages, would be overcoming transportation and distance barriers. So getting the region involved in providing maybe fuel or boat or transportation for these occasions, getting it pushed out to provide the village boats to bring clients up and patients and persons who are interested in accessing care. It's a really great idea. Again, it's about fostering a relationship within the community so that the community can help you to help themselves. Now, decision making involving community members is one of the most, is basically one of the best ideas you can have in rural settings because these communities, they will not feel that you're coming into their community to basically implement measures against their wishes. They will be more open into listening to you and to basically implementing whatever measure that you would tell them to based on evidence, of course, and make sure that it aligns with the local needs, preferences, resources, cultural beliefs, and so on, because we want to, again, respect all of these things. Because in what I find in rural communities is if you disrespect their cultural beliefs, that's going to basically build a wall that you may or may not be able to ever get over again. So please, that's an important point to remember.
I definitely like that. Getting communities to help themselves.
Definitely.
And definitely, this is a wealth of knowledge that you're sharing from your experience, from the lovely work you would have done in rural communities, rural Cameroon. Um, and so, in closing, would you like to share any experience and success stories you would have had in any particular area providing care and treatment towards persons living with HIV, and how best you were able to impact that community?
Definitely, Doc. One of the things that come to mind for me is that in my providing care for my patients in Cameroon, I would have found that one of the barriers to care would have been them coming to clinic, accessing their charts, and going to the pharmacy because of how the clinic was laid out. Everyone would have been able to see what everyone is doing. So one of the things that I found was helpful would have been to take an approach that meant that the patients had a no hands chart approach, meaning that I would have kept the charts in my office and I would have told them that when you come to see me, tell nurse that you have a headache or you have a cold. They would triage your patients, they come into you, and of course, you know your patients because they're small communities, it's a small amount of patients. You do up your prescriptions and write up your charts, and I would keep a few bottles of medication in my office that I would give to them. So they would not have to go to the pharmacy because obviously the pharmacist is someone from that community as well. So that way, because you find in small communities, one of the major barriers to care would, excuse me, would be confidentiality. So overcoming that barrier, it's a bit hard, but you have to be innovative. So I kept medication in my office and I gave it to my clients and I would send them for their vitamins at the pharmacy. So it's a legit consult. It's a legit way of doing things as well. And one of the greatest things again has done of late, with your help, of course, Dr. January, would have been the implementation of the HIV self-testing. So now patients have that option of going into their homes and having a test done if they're not comfortable coming to the community. If the consult tester maybe someone they know, a relative, a friend, a neighbor. So they have the option now of doing that test at home. And that is one of the greatest comfort I think for persons living in rural communities that ensures confidentiality on their end. Additionally, I always try to remember when I'm dealing with rural communities to ask the communities, the leaders, the patients, what they want to see as progress for their community. What is it that they feel that as a community they need, and try to basically tailor my approach to health in that direction. And I would have found working in Cameroon for that period of time that the patient load that I would have had as compared to years before when we would have had other physicians there. It was a big difference, basically, because of the approach that was taken. Thank you, Doc.
Thank you so much, Dr. Lakshmi Narain. The wealth of knowledge you shared with us definitely was inspiring, and there's so much that we can learn from you and the work that you would have done. Not only talking about getting the involvement of community leaders, principally, and using local talent. I really like the way you actually coined that to leverage local talent when it comes to approaching care and treatment within communities. I like the stories you share of your experience in Cameroon and what was done and some of the best practices you've utilized. It's sad to know that even a place like Guyana, despite having 5G and so many other different internet services, we still have to use satellite and radio services for communication. Language barrier, like many other rural communities, continue to be a challenge, and I'm sure that in itself, getting a message the way we fully want persons to understand it, especially when it comes to HIV care and treatment, can be challenging. And the level of education to way to put it over. But you would have done well in trying to get people to help to deliver these messages. Culturally tailored education, and that's one of the techniques you use that actually try to combat against language issues and language barriers. And definitely that's something that we can actually approach in many other parts of the world and trying to ensure we try to tailor our not only education messages on prevention, but on treatment that it also has to be tailored to the community. And so peer support, trying to get many local talent, whether it's a farmer, pastor, whoever, that was very inspiring. And as well at the same time, your collaboration with many of the other community members to help execute your work. Your success story that you shared is very, very much inspiring as well. I really like those. And I like the way you said it's a no hand chart approach. And I think it's something that we can actually encourage many of the other communities to try. Keep because it's one medication that we use. It's our first line medication of using TLD, integrase-based inhibitor drug. It's a combination drug, of course, but at the same time, persons they're not going to be stigmatized. They're not going to face any kind of discrimination, especially given a small community. And then I like the success story of HIV self testing. Thank you so much, Dr. Narain, for sharing with us your care and treatment approach over the past few years. And since we are pressed for time, allow me to go straight into our third speaker, Dr. Keisha Chin. She would be sharing with us a little bit on how persons within rural communities approach stigma and discrimination, how as a program they approach stigma and discrimination, and its impact it has too on those communities and any success stories. But before she do speak, allow me to introduce a little bit and tell you a little bit about Dr. Keisha Chin. Dr. Keisha Chin is a clinician, but also the current national STI coordinator for the National AIDS Program Secretariat. She would have worked a number of years as a primary healthcare clinician, not only within the capital of Guyana, Georgetown, but also in rural communities, which she would share with us that experience. She has the responsibility of overseeing the expansion of PrEP services within Guyana. That those are medications to use that prevents persons from getting HIV. She would have previously served as the medical supervisor of one of our primary healthcare facility in Georgetown, the Isla Penitence Health Center. She is also a lecturer at several universities, and she does quite a lot of extracurricular activities with her spare time in terms of volunteerism and humanitarian work with the Rotary Club of Demerara. She also mentions that she's the foundation chair, which helps to provide grants that focuses on rural communities. And I'm sure if she can stick in a quick 30 minutes or a minute can tell us a little bit about that. So without further ado, I do welcome you, Dr. Chin. Please do share with us. Turn on your camera. Let's let everyone see who you are, and let's hear from you.
Thank you very much, Dr. Narain, for that introduction, and good afternoon again to everyone. I have the pleasure of speaking to you this afternoon on a topic that is addressing HIV-related stigma and discrimination within rural communities within Guyana. So prior to me getting into the meat of my presentation this afternoon, I think it would be best for us to just briefly revisit the two terms that we are utilizing and we are going to be having a bit of focus on, which is stigma and discrimination as it relates to HIV and HIV services. So stigma, particularly for HIV, would be any irrational or negative thoughts, behaviors, beliefs that a person may have as it relates to persons living with HIV. And then discrimination or HIV-related discrimination would be the act itself of treating persons who are living with HIV differently in comparison to your attitude or your behavior, how you interact with persons who are not living with HIV. Unfortunately, we are, or within our rural communities, stigma and discrimination does exist. We are tackling that particular issue head on as a national program to ensure that whatever response is coordinated, that stigma and discrimination is an aspect of HIV services. Whether it's for prevention or care and treatment, it's an aspect of HIV care that we are addressing and that we are trying to mitigate the impact that stigma and discrimination may have within the work that we're doing for persons living with HIV. So as it relates to the impact that you may see within our rural communities, I think I should say for rural communities, you do have some specific stuff that you may notice that may just be noted in rural communities, but a lot of it is still comparable with what you may also note in some of your rural communities. But I'll try my best to differentiate and to highlight specifically for our rural communities. But in terms of some of the universal impacts that we may note within our communities, in no particular order, I'm going to highlight just about three of them. The first one would be barriers to accessing HIV-related services, particularly HIV testing may be hindered. Now, how do we note this, or how is it noted for particularly for our rural communities? As as the two previous colleagues would have mentioned, our rural or hinterland communities are very small communities. They have a very small population. They're very isolated communities in very far-flung regions within Guyana. So you can look at it in two different aspects. One would be from the viewpoint of a healthcare provider. One of the things that you would see for impact, or one of the impacts that you may notice for HIV-related stigma and discrimination, is that for healthcare providers, you may have reservations or some reluctance coming from healthcare providers to actually be involved in HIV care. We have noted that because of them being a very small knit community and some misconceptions that they may have about HIV and other forms of sexually transmitted infections, you would find that persons that are looking within the community for a particular job may be reluctant to be employed within HIV services because they think they either have some sort of thought to themselves, or they think that the community would think that once they're working within HIV care or HIV-related health services, that they themselves probably have HIV as well. So you find that can be a barrier or a limitation to actually having persons work in the field within rural communities because of misconceptions and stigma and discrimination that exists within those communities. And the other one can be specifically for the clients. My two colleagues would have already touched on the characteristics of our rural areas, where because of the geographic layout or location of these rural communities, one, you would find that the small populations, persons always have a fear of if they probably have been exposed to HIV, or if they're living with HIV, they feel that if they go to the health facility within their small community, they are going to have an encounter either directly or indirectly with someone that is from their community. So that in itself is a barrier because they would come to the conclusion that they may or the possibility exists for breaches in patient confidentiality to take place. So we would normally find as if a person, let's say for example, thinks that they may have been at risk and they want a test done for it, or they want to have a test done for them, they prefer to not visit those particular facilities within their community, but to venture off and probably wait until they travel out of their community, or even wait until a visiting team of healthcare providers are within the community so that, it addresses any fear of breaches in patient confidentiality. Another thing that you can note as well is that a lot of persons, when it comes to care as well, they prefer, to travel out of their regions to have care done. So those in itself are barriers to providing either preventative services like testing, and it also is a barrier to HIV care treatment and support that is available within those communities, but persons are reluctant to access those services within their community. Another impact that we have noted within our rural communities would be that persons that are living with HIV, their mental well-being and emotional well-being is affected. You would normally find that because the communities are very close-knit, very small populations, oftentimes persons who are living with HIV and persons within their family are aware of their status, or persons within the community are aware of their status, they're rejected by their family members, they're rejected by the community, they're isolated from participating in certain activities, certain jobs may become inaccessible to them as well. And that ultimately can cause some amount of psychological distress for our clients living with HIV in those particular communities. Another impact that is very present within our rural communities as well would be one that ultimately results in adverse health outcomes. Um, because my colleagues would have touched on it before, I prefer on this particular point to give you an example. One of the communities one of the hinterland regions that I would have worked in before, myself and other colleagues from the National AIDS Program Secretariat would have quite recently visited that community to offer combination HIV prevention services. So we offered HIV testing, screening for various forms of sexually transmitted infections. We offered condoms, lubricants, IEC materials, pamphlets, brochures, etc. And one of the things that was coming out of that visit is that the persons within the communities would have expressed to us that they are reluctant to actually go to the health facility to receive. This is a person living with HIV. They were reluctant to go to the health facility to receive their medication because even if they were to enter into the consultation room with the doctor and no one else there was present, the mere fact that they're going into the health center or into the hospital, their fear is that the persons that are working within that particular establishment has access to their information, or a rumor may be started, or the person may see them and say, hey, because they're so familiar with that person, the person might be like, well, I saw you at the hospital or at the health center. What were you there for? And then it puts them on a spot. So in that particular community that we had visited, what the doctor would have actually come up with, similar to, something that Dr. Narain would have had in place to help out her clients living with HIV, would be that he made alternative arrangements to have consultation and treatment drop off for those clients. So instead of having them come to the facility, what he would normally do is he would share his telephone number with them. He would get into contact with them, or they would reach out to him first, and he would have a particular drop-off point, which would either be at the corner shop, at the supermarket within the community, or it would be at sometimes even at night. At night, he would visit probably one of the night spots where there's probably commercial sex workers visiting there, if those were any of the clients that he was attending to. And he would provide his consultation, and he would also provide drug drop-off where they would receive their medication instead of them having to feel that discomfort of coming into the health center and having that fear of their status being revealed, or having an encounter with someone that they were pretty familiar with. So That would be some of the impact that we would normally note within our rural communities. Now, if I may to advance, I would want to touch on very quickly on some of the strategies as a national program that we have implemented. So before I get into those strategies, I would just like to share with everyone that us at the National AIDS Program Secretariat, we're guided by our National Strategic Plan, which is popularly referred to as our NSP HI Vision 2025. And the vision of that HI Vision 2025 document is that for all persons or all people living in Guyana, regardless or irrespective of their HIV status, their gender, or their sexual orientation, that they are able to live a healthier life and to enjoy a better quality of life that is free from stigma, discrimination, and free from that burden of HIV and from that burden of AIDS and new HIV infections. So guided by that particular document, we have a few impact results that we are working to ensure that as a national program, we're mitigating the impact that HIV, AIDS, and other sexually transmitted infections have in Guyana, particularly within our rural communities. So two of those impact results would be that by the year 2025, that we would reduce by the year 2025 the HIV-related stigma and discrimination. And the second one would be that by the end of the year 2025, we would also reduce the incidences of HIV-related stigma and discrimination for persons living with HIV and also for our key populations, which would be our MSMs, men who have sex with men, our transgenders, our commercial or female sex workers. And by extension, we also target our vulnerable groups like our pregnant women, our adolescents and teenagers, our minors, our loggers, and other minority groups that you can find within these rural areas. So a few of the things that we have pulled from the guides provided within our strategy would be to ensure that or a few of the recommendations rather, would be to review and update any existing policy or laws that we have in Guyana. And the point of reviewing and updating these existing laws and policies that we have in Guyana would be to ensure that it promotes up-to-date human rights standards to ensure that they're applicable within our settings, not only within our rural areas, but they're also applicable and implementable within our urban and rural settings to ensure that we also address gender-based programming, to ensure that we invest in the reduction and elimination of all forms of stigma and discrimination with a particular focus on healthcare providers, communities, and individuals who may also be experiencing some form of self stigma or some form of discrimination within their particular setting. So very briefly, a few other things that we have been addressing or implementing as a national program. Our current policy, our HIV stigma and discrimination policy, has been reviewed. A framework has been, we do have an existing framework, and that document is currently under revision. So as a program, we can be proud that pretty soon we'll have a revised HIV stigma and discrimination policy that caters as well, not only to urban communities, but to rural communities as well. We are in the constant habit of partnering with private organizations and with civil society organizations, with NGOs and with other faith-based organizations, as my colleagues mentioned before, to ensure that we have a robust and ongoing anti-stigma and discrimination campaign that's across the board, multimedia, on television, on radio, when we're interacting with target populations within the various communities. We have quite recently, as a program, we have engaged professionals that fall under the paramilitary and military umbrella as well, where we would have conducted workshops with them to ensure that whenever they're interfacing or interacting with persons who have been subject to some form of stigma and discrimination, how best they can handle that situations and not perpetuate further stigma and discrimination when persons seek that sort of help or intervention from them. We also
Definitely,
have,
these are general lovely strategies that are being implemented. And I know we are a little bit pressed for time. Maybe you want to share with us any success story that you would have had in any specific rural communities while implementing any one of the strategies mentioned before.
Well, I would probably highlight the one where I that I already shared previously, where us visiting that community, we simply did not take the complaints or the concerns for the persons living with HIV that we would have interfaced with during that particular community outreach, but we would have taken it a bit further as a national program to have conversations and conversations that are still ongoing with healthcare professionals from those particular communities to investigate if those complaints are true, and to not only investigate but to come up with ideas and to come up with strategies of how we can best address them to ensure that persons within the community reach a point where they feel safe and they can visit those communities without fear of experiencing any form of stigma and discrimination. So I'm happy to say that within that particular community, we're in constant contact are in constant communication with the healthcare professionals within that community, and the situation has improved. So you're seeing persons, more and more persons that are living with HIV, instead of venturing out of the community, they're now visiting the health facility within that particular area.
Thank you so much, Dr. Chin. We're not finished with you. Definitely, you've set the foundation to move into a panel discussion to talk a little bit more about HIV care and the approach towards HIV care and the way forward. But definitely, you would have shared with us a wealth of knowledge as it has to do with the approach to stigma and discrimination within rural communities, not only by defining clearly what is stigma and discrimination, but its impact, especially on small communities, communities where everyone knows each other, and there's that fear of your information being exposed. And techniques that would have been applied by many of the healthcare workers and clinicians and adapted, even like dropping off medications to persons' home so that they can actually receive adequate care and treatment. The reluctant to access because even in the healthcare HIV sector, many persons don't want to work with the HIV sector because fear if you work with the HIV program, the National AIDS Program Secretariat, you would be deemed as having HIV or AIDS. At the same time, too, I like the points that you mentioned about persons traveling out of communities to seek healthcare services. Just to avoid any form of stigma and discrimination. And definitely, mental health has always been at the forefront of in many other illness, but not forgetting HIV does play a huge role. And in these small rural communities, it can affect those communities. And so, moving straight into our second session of talking about the way forward for HIV in terms of reducing stigma, HIV prevention. I would ask you to quickly share with us in 2 minutes any message or any words that you'd like to tell us as the way forward.
Okay, so for myself, what I would want to highlight is that as a national program, we are in the constant habit of evaluating and reviewing the activities and work that we're conducting as a national program to ensure that we are able to improve strategies that we're implementing and to properly mitigate the impact of that HIV, AIDS, and other STIs would have within our rural and urban communities. So one of the things that I would probably want to highlight is the success that we have had at improving our combination or HIV comprehensive combination services, prevention services. As would have been mentioned before, we're not only offering as a new initiative self-testing kits. So for persons that prefer, they have the option of testing themselves within the privacy of their own homes. And also that linkage to care has been something that we would have addressed as well. So whenever we have a person with a preliminary positive result, they're advised and they're linked to care so that a confirmation test can be done for them and they're navigated directly into care. As part of our combination prevention strategy as well, I would like to highlight that within the last year or so, under your tenure, Dr. Jagnarai, we would have been able to successfully expand and optimize our PrEP services, pre-exposure prophylaxis, which is also available within our rural communities. So initially, when it was piloted, it was available to the seronegative partner within a serodiscordant relationship, but we have further expanded that service to include not only our key populations, but persons within our general population as well, as long as they have an on-the-spot initiation or on-the-spot initiation for PrEP is something that is available, whether it's event-driven PrEP or continuous PrEP. So those are a few of the things that I would want to highlight as successes, recent successes for the program, and they're all available within our rural communities. Dr. Jagnarai, I think you're muted.
Sorry about that. So thank you so much for that. Definitely PrEP being an initiative that is not totally new to the world, but new especially to Guyana setting and the Caribbean. I'm happy to hear that not only nationally as a program we can offer PrEP to Guyana, but many rural communities can have access to PrEP. And so over to Dr. Lakshmi, Narain, and Medex Judy Atkinson in 2 minutes, share with us any closing words as it has to do with HIV prevention, reducing stigma discrimination, or if you want to focus on the given treatment.
Definitely, Doc. Thank you. For me, I would basically want for our healthcare workers and the persons living in communities to basically remember that getting HIV, it's not a goal set by anyone. It's something that happens, and when it happens, we have to deal with it. We have to support persons living with HIV, and as a healthcare community, we want to promote integration of services, retention and care. Also, importantly, is to address any social determinants of health, research and innovation, and partnership, especially for rural communities where those resources are limited, and to ensure that us as healthcare workers provide the care and the quality care at that that's necessary to keep those persons in care, maintain them there, and get them on ARVs as soon as possible. Because now we do use treatment as a form of prevention as we move towards U equal U, untransmissible, undetectable, untransmissible. So
Thank
I
you
just
so
want
much.
to thank you, Doc. Go ahead.
Go ahead. Go ahead. I thought you were finished. My apologies. Go ahead.
I just want to encourage our healthcare workers and say thank you to yourself and our healthcare workers in Guyana for doing such a great job thus far. It's really appreciated.
So thank you for highlighting the importance of focusing not about you equal you within our healthcare system, especially in rural communities. It's one of the many approaches that is shown to be evidence-based. It's one of the way that we can achieve epidemiological control of HIV. And so we want to ensure that the new interventions, the best practices, the evidence-based approach that we apply centrally, it can be experienced by many of the rural communities. And so over to Medex Judy Atkinson with a lovely story from Maruka. Um, over, over to you. I think you're muted, but
Yes, doctor. Hello.
yes, we can hear you. Go ahead.
Um, I was off a little while, so I'm a bit lost. Sorry.
And so we were asking to share any message in terms of closing words that you'd want to give around HIV prevention, care and treatment, stigma, and discrimination.
Um, for me, I would like to commend the health workers in those hinterland region, who is working hard in terms of prevention of HIV and offering care. Um, I would like to see like improvement in terms of prevention, in terms of the distribution of PrEP, because there's a little stigma attached to when it comes to accessing PrEP, because we usually offer it at our care and treatment clinic. But I would like to see a more integrated approach so that client would feel comfortable accessing treatment in terms of PrEP.
Thank you so much for that, for highlighting the need for PrEP within our community. And so, to you, our listeners, all of you took the time out to join us. Definitely, there have been great achievement when it comes to HIV care in rural communities. We would have heard lovely stories from our three esteemed panel, but there is a lot of work that needs to be done in improving services, especially when it comes to providing equal care to all and reducing stigma and discrimination. And so before I close off this session, I know I have another ambassador for the Rural Seed on board, Ms. Sena Kaitan. I will allow her to share a few closing remarks, and then we will close this session.
Thank you for this insightful discussion. I think it was really nice to hear another perspective from the other end. And I really must commend the work you all have been doing in Ghana. Very interesting to hear all your stories, your rural stories, the community, and yeah, a lot of insightful messages, I think, from this session. So, yeah, thank you for hosting this, Tariq. It was really nice and informative. And we look forward so that you can join us for the sessions in future as well. And yes, thanks a lot.
Thank you so much. And so, without further ado, keep up the good work that you're doing. Thank you, Dr. Lakshmi Narain, Medex Judy Atkinson, Dr. Keisha Chin, for sharing with us. And those of you who took time out to join us this afternoon, thank you so much. This recording would be uploaded, and I will share the link at some point with you. So, have a good afternoon, and bye bye.